Hematuria. Hematuria, by definition, is red blood cells present, not red urine, not positive dipstick for hematuria. Hematuria means you see red blood cells. 3 to 5 red blood cells per high power field. Pyuria is going to be the same thing, 3 to 5. It's very common. Look how common it is. Now, the dipstick analysis, again, false positive, false negatives. Let's highlight a couple of them. False negatives, vitamin C. Vitamin C prevents the reaction that identifies the positive reaction on the dipstick. How much does it take? 250. Some people even say 60. That's a multivitamin. Prolonged exposure of your dipstick to air. Right? You have to have dipstick control in your clinic. That's why you're supposed to actually monitor the dipstick. You're supposed to put the name on it. They're supposed to put the cover on it. Since you never go back there, most likely, you don't know what's going on. So when you start having a lot of false positives on this stuff, you have to go back to your CLIA waiver stuff and see if you're really doing it right. False positives. Now you have a positive dipstick, but when you do it microscopically, you don't see the red blood cells. Oh, myoglobin, that makes sense, right? Free hemoglobin for hemolysis. How unlucky would you be if you don't have a history for that one? But antiseptics come inside of there again. Bacteria could do it. Bacteria could give you a false positive red blood cells based on these bacterial peroxidases. They interact with the test itself. And again, we actually have foods and chemicals that could react. So I think one of the good books out there is that Wallace Interpretation of Laboratory Test. When you get a laboratory test, that just doesn't make sense. Consider false negatives, consider false positives. We always go after what we think it is, but if it doesn't make sense, then look up in a book someplace, what are the other possibilities? And that's why the false positives and false negatives on the urine are very helpful. Oh, all dipsticks should be analyzed by microscopy within 1 hour to confirm. If you end up having hematuria, working in the ER, you have hematuria, you put it in the refrigerator in 6 hours, you might also just get rid of it now and throw it away. Because a dilute urine will lyse the red blood cells. There's a lot of stuff in urine that will destroy red blood cells if allowed to sit around. So if you're going to culture the urine, if you really want to make sure it's a urine infection, let it sit around for 24 hours, and then you'll be right. You could call it a urine infection, let it sit for 24 hours because you'll grow something. So when you end up getting a fresh urine, that's where you need to plate it off. That's where you need to analyze it for hematuria. It's right away, or I would consider your chances for false negatives go way up. So hematuria evaluation. Look at the red blood cells. Look at somebody that's smarter than us to look at that. Because what you're looking for is monomorphic red blood cells or dysmorphic. Monomorphic red blood cell means the normal appearing red blood cells, the little donuts that we have. Dysmorphic means they're destroyed, they're shapen, they're crenated, they're burred, there's something's really wrong with them. Usually a dysmorphic means it's coming from the glomerulus. It's being squeezed through the glomerulus, and that's what gives you dysmorphic. Monomorphic could be crying from the tubules, the kidney stone, the bladder, the prostate, any place else. So if you have monomorphic red blood cells, that's usually not from the glomerulus, and it doesn't have any other company. No normal creatinine, no protein, no other features. Then a lot of people will say, get a CAT scan. What are you looking at a CAT scan for? Cancer. Bad miss, isn't it? So if you have monomorphic red blood cells, get a CAT scan. If the CAT scan is negative, then if you're at very low risk, and I gave you some ideas, if you're at very low risk, consider yourself done. If you're not at very low risk, then go cystoscopy to look for what? Bladder cancer. A bladder stone won't kill you, right? An undetected, non-obstructing, ureteral stone won't kill you. A non-detected renal cancer, bladder cancer is really bad news. Now, people that have done this, since hematuria is so common, 1 to 3%, right? My area, Blue Cross in my area, will not allow you to do a CAT scan on one hematuric episode because it's so common. They say, we want 2. We want 2 persistent hematuria before you get your evaluation. Now, you may be in a little dilemma. You got 1. We know it could be intermittent in nature, so what do you end up doing? A, lie. B, have the patient just pay for the CAT scan themselves out of the pocket, $1,000. What do? I don't know what you do. Most of the times you do something. If you're at high risk, and our urologists, they're at high risk, they say, da-da-da-da-da, and Blue Cross usually caves on in. But most of the times they'll have another, a hematuria. You only need 3 red blood cells, right? So if your lab says 4, you flunk. You just flunk again. Isolated, non-persistent hematuria is typically benign. Isolated, not persistent. See, that's how the blues are doing this too. Isolated, non-persistent hematuria is usually benign. Now, menstruation is not really, what do you call menstruation? A false positive urine? I don't know what you call it. When you're looking at the urine, there's blood in it, right? But it's from the menstrual cycle. Those two orifices are pretty close to each other for the most part. So it only takes, how much blood does it take to get 3 red blood cells per ml? Not very much. Matter of fact, almost none. So I don't know if some people call menstrual-related blood a false positive. I will too. It's a false positive. It's really not in the urine. It just got dropped into the bucket. Glomerulonephritis. Now the causes of hematuria, glomerulonephritis. If you have glomerulonephritis, there's usually a company it keeps. The red blood cells are usually dysmorphic. You have red blood cell cast because a lot of red blood cells are coming through now. They're joining each other and forming cast. They usually have proteinuria. If you have isolated monomorphic, you don't go after the glomerulus. Renal causes, look at that, associated, now we're going to blame the kidney. It has protein in there, but they're not dysmorphic red blood cells. It's not coming from the glomerulus. So what renal causes? I gave a whole bunch of them. AVMs could do it, an increased excretion of calcium or uric acid. How does that work? Calcium and uric acid irritate the tubules. And it kind of like scratching a board on down, and it bleeds a little bit. There's where you get your red blood cells. Medullary sponge kidney, we'll talk about that. Polycystic kidneys could have actually hematuria. Renal artery emboli, thrombosis, sickle cell, there's all sorts of stuff. It is hematuria from renal cause, but it's not from the glomerulus. Urological, this is just, you don't have to, don't get caught up in what's urological and what's renal, but look at urological now. It said now you don't have any protein, don't have any protein there, you don't have dysmorphic red blood cells, and you don't have erythrocyte cast. Now you have this, BPH. See, they're saying it's not the renal system or the kidney system, it's the BPH. And that's typically what the guys will end up having. And the cancers, there's the bad player right there. Then urinary tract infections, kidney stones, etc. Some special circumstances, benign familial hematuria. These are people who said, well, let's get a urine. Doc, it's going to be positive. Why did you say that? It's been positive since I was 12. That's benign familial hematuria. You're kind of born with it. I don't know the genetics of that, but it does run in families. So I don't know if it's autosomal dominant with variable penetrance. But no one knows what to do with these people. Some people will check a periodic urine and creatinine. No one knows what to do. Most of the times it is benign. Nothing happens. Loin pain hematuria syndrome. Loin pain is your flank. It's supposed to be your flank. It hurts, and you have red blood cells. Severe flank pain, they get into trouble. These people could actually turn into addiction problems. It hurts a lot. They're asking for their kidney to come on out, and you don't find anything. Creatinine's fine, CAT scan's fine, ultrasound's fine, urine's fine, except for intermittent hematuria. If they do kidney biopsies, it almost looks like minimal change nephrotic syndrome, but a lot of times they're normal. Most of the time it's pain medicines, opioids. Sometimes if you donate